Welcome to Healthcare Rounds. I'm your host, John Marchica, CEO of Darwin Research Group and faculty associate at the Arizona State University College of Health Solutions. Here we explore the vast and rapidly evolving healthcare ecosystem with leaders across the spectrum of healthcare delivery. Our goal is to promote ideas that advance the quadruple aim, including improving the patient experience, improving the health of populations, lowering the cost of care, and attaining joy in work. Please send your questions, comments, or ideas for Healthcare Rounds to podcast@darwinresearch.com. And if you like what you hear, please don't forget to rate and review us wherever you get your podcasts. Let's get started.
Today, John speaks with Dr. Thomas Young, board-certified family physician with more than 35 years of medical experience. He is recognized as an innovator and thought leader in the fields of consumer-directed healthcare and population healthcare management. Dr. Tom Young is the founder and chief medical officer of nView Health, an innovative software company that helps providers better identify, treat, and monitor patients with behavioral health conditions.
Dr. Young, thanks again for taking the time today to speak with me and some important behavioral health issues. So the magic of podcast editing, your bio will have been read in by this point, but I thought it's always good just to orient people to start off by saying, tell me a little bit about your history and your background.
Okay. My history, Texas boy, went to medical school in Texas, did some things, did some residencies, came back, got into teaching, started teaching down in Texas at Baylor, moved to Idaho in the late 70s to teach medicine and stayed here. Practiced family medicine, worked in a lot of administrative roles, oversaw Medicare for many, many years in Washington, Idaho, and Alaska. Managed Medicaid here for 6 years. I've done some things in the entrepreneurial world along the way, but still actively practice. I manage a substance abuse clinic, a college clinic, and provide some services in a therapy clinic as well.
Great. So still very active. And then today we're going to get into nView in just a little bit. But that's good. I appreciate your giving me that and our listeners that upfront background. So patients, I was doing some research before this. I wanted to get a firm number. I saw a JAMA article that said patients with behavioral health issues tend to cost, I think it was a Canadian study that said 2x your typical patient. I've seen other numbers that show 3 times as much the average patient due to comorbidities. And so my first question is, and I'm always thinking of this kind of in a health system or integrated health system standpoint. That's my background, my expertise. And it's been my sense that health systems have largely ignored this patient population. Not all of them, but a lot of them have largely said, well, behavioral health is for someone else, or we're not going to put a lot of resources against that. So my first question is that your experience? And if not, then tell me why not. And if it is, why do you think that's the case?
Well, I think historically in this country, if we talk about sort of the history of mental health in this country, for years and years and years, back into the early days of the 1900th century, we put people with mental health disorders in institutions, and we stigmatized all kinds of mental health disease. And then in the 60s and 70s, a sort of a new generation of folks came along and said, we need to clean out all these institutions, and we're going to send these people out in the community to be cared for instead of in state or federally based institutions. That was a dramatic change that kept rolling through society from the 70s on, because now we had people in the community with serious mental illness, again, stigmatized. Mental illness has always been more stigmatized than any other sort of health disorder, save maybe sexually transmitted diseases. Both of those sort of don't get high marks for treatment and care.
Sure.
And so the reality is it got pushed into the private sector. A lot of these people are in the Medicaid populations because of income and poverty levels. And so hospitals sort of shunned it off to psychiatric hospitals. That's where these people belong. They don't belong in our medically based facilities. And so hospital systems paid attention to those things that got paid for, rightly so, those things that were extremely common and those things that we knew how to treat. And if you look back in the history of treatment, psychiatric treatment is still sort of only medications. We're just now looking at new kinds of things, TMS, ketamine, psilocybin.
I saw that article. Was it last week or the week before? Impressive.
Yeah. So now we're getting into sort of the more neuropsychiatric kinds of treatment paradigms and starting to look at the brain and behavioral health in a different way. But hospitals are slow at catching up to that. And so fundamentally, most of healthcare, biggest percentage of healthcare, probably 80 to 85% of all diagnoses of mental health disorder in this country are made by primary care docs, pediatricians, internists, family docs. They write most of the prescriptions for these expensive psychotropic drugs and unfortunately aren't tooled up to really make an efficient diagnostic system around that particular phase of healthcare. So again, by hospitals focusing on those things that we know best, those things that we have treatment for, those things that are medically remunerated for. So we're getting closer in a systems world, because now we're reversing that, saying now we need to integrate behavioral health back into primary health care for just the reason you said. Your numbers are spot on. Even more specific, for example, diabetes. Patients with unknown and untreated psychiatric or behavioral health disorders spend 6 times as much money as the same or equivalent patient who has either a treated or non-behavioral health disorder. So we spend the money, but we spend it on the health side, on the payment side, if you will, payer side. Almost every person with a chronic disease has some comorbid mental health disorder. And when you say chronic diseases in this country, man, that's a lot of people.
Yeah.
Diabetes and hypertension and COPD and renal disease all come with the person attached, if you will.
Right, right. So why is it the case, Dr. Young, that I understand why primary care would be the ones, sort of the caretakers, making the diagnosis, to your point. Somebody comes in and they're in a bad way, we'll just say. Why did they, if they're going to prescribe, why did they not then refer to a specialist in the same way that if I walked into my doc and I had out of control blood pressure, I mean, really out of control, he'd probably send me to a cardiologist, right? So why does that not happen? Why is it managed solely, or as you said, 80% of the cases are plus by primary care?
Well, I think one of the things, John, is that there aren't enough of the people that are really needed in that space, in that referral space. Let me give you an example. When I first came to Idaho many years ago, there were 2 in the entire state, child and adolescent psychiatrists.
Wow.
Okay. I think now, I could be wrong, but I would guess maybe 12. Actually, board certified child, pediatric, and adolescent psychiatrists. But again, psychiatrists in general are undersourced in this country. We've tried to make better of that with telehealth. Telepsychiatry is one of the first things to really get up and going in the tele space, which was trying to cure the access issue. Because contrary to when I was practicing, for example, if I had somebody with a bad back, I could literally walk them upstairs to a neurologist who would see them. We would get an MRI. And if it was a surgical problem, we could fix it that day. Now, if I had that same patient with out of control psychiatric problems, I'd be calling around trying to find a psychiatrist, number 1, that took his insurance, number 2, if it was ever insured. Or number 3, my only alternative was either send them to the ER so that the ER would then have to put them in a psych hospital. So the resources are entirely different for psychological care than they are for medical care.
So from a physician's perspective, do you think that the prevailing notion is still that mental health is over here, physical health is over here, that the prevailing notion is that we're not working with them in an integrated fashion, or do you see that as changing?
Oh, it's definitely changing. There's no question it's changing. I think that was the way it was for a protracted period of time. Even though in all my teaching years, I used to tell primary care docs, look, guys, gals, half the people that come in your office are not sick. And by that, don't necessarily have a physical illness that you're going to go, let me listen to your heart, let me take your blood pressure, let me tell you what's wrong with you, let me draw your blood. So that's been kind of the norm. We've sort of known that. And when you look at the numbers, 1 in 5 people in this country have significant depressive symptomatology. That's a lot of people. That's a lot of people walk a lot of doors. So I think we've sort of known it, but now we really are seeing more attention paid to it by systems, large systems. System providers are now focused on it. If you look at the EHR providers, Cerner, for example, really focused on developing products into the EHR space that help integrate behavioral health into those systems. So even the large system providers are now providing services that sort of push us that way. We will see that turnaround, but we still will be undersourced for some of the basic services like therapists, social workers to fill the gaps, peer support groups, substance abuse clinics to work in that space will still be a problem.
So anecdotally, we hear on the news that COVID-19 has caused all sorts of behavioral health issues, mental health issues, depression, isolation, in kids as well as adults. What have you seen over the last year, and what has been the response by the providers that you're connected with? Have they stepped up their efforts in any way to combat and potentially an increase in these issues?
Oh, absolutely. I think we've seen it in a number of spaces. As you alluded to, John, children particularly have been impacted quite dramatically. Now we're really seeing not only activity, but action in, for example, putting counselors in schools so that children have access to that service and don't have to be taken out of school, taken somewhere, wait an hour, 2 hours, mom misses work. We can do this inside schools. I know one of the school systems here locally has put a tremendous effort into that, particularly now that they're bringing kids back in and they're seeing the ramifications of social isolation in children. We have seen employers and companies focus on trying to do some of the things. We've got new terminology for what has disease processes that have been created. For example, Zoom dysmorphia. And if you don't know what that is,
I don't.
Okay, one of the things I noticed very early on when my life changed from going to meetings and going out and meeting people and helping people in their practice. One of the things I noticed that I didn't ever normally do was look at myself. You know, you look at yourself and you comb your hair and you brush your teeth. But Zoom dysmorphia has sort of crept into the jargon for body dysmorphic disorder patients, people who are obsessed with problems. And we're starting to see that from people sitting in Zoom meetings, because in a Zoom meeting, I see you right here and then I see me right there. And so this attention to the detail of our faces, what are our faces doing? What are our eyes doing? Has created a whole new jargon, if you will. And so where that has come in, we've also seen new ways for people to deliver care, not only just by tele, but by groups, for example. Our company does what we call Zoom 5 o'clock after hour parties every 2 weeks. So people that are seeing each other in Zooms all day can change that, and we've created ways to bring people back together. We've done strange things like today, like we've got one coming up this week. I think it's Hat Week. So how many crazy hats can you get together for the cocktail party? So people are doing that. We're seeing things done. And in the healthcare space, yes, healthcare providers have started to step up and look to assistance from computer-based therapy programs that they can refer their patients to, certain apps that they can offer to patients that may be helpful, mindfulness apps, that sort of thing.
Mm. So what role, just quick change gears, and then I want to get into nView. What role do you see the pharmaceutical industry playing? And obviously they're developing drugs, but do they have a larger role to play in the behavioral health space? Is there something more that they can be doing to improve patient care?
Well, I think the pharmaceutical space is sort of the mainstay at this point in time for what we do in behavioral health. There are a whole lot of new things coming. We alluded to earlier on the new psychedelic drugs. We've seen advances in drugs like ketamine, which is a fascinating drug when you think about the history of ketamine and its use. My use of it for years was in the emergency room. Children that were traumatized, injured, broken legs, whatever, I could give them a shot of ketamine and I could take care of them. And I didn't have to worry about low respirations or their breathing or any of those other things. So I could fix a broken leg or create, go in and tie off an artery that needed to be fixed. But ketamine in itself, the other amazing thing I see now, people can come in wildly suicidal, get a shot of ketamine, and an hour later not have a suicidal thought in their brain.
No kidding.
And so we've seen that drug go from an injectable format, IV ketamine treatment clinics for severe depression, and it works, to a nasal, what's called S-ketamine. Now, does it cure all? No, but it's a really exciting adventure in really significant treatment improvement. I mean, these are refractory people that in the old days used to get ECT.
Right.
But now we're doing that. We're seeing that with the psychedelics, the psychotropics. Some of the initial studies out of Johns Hopkins demonstrate you could have people who are alcoholics, and I mean severe. They're drinking, 15, 20 mixed drinks a day and still function, working every day. And they go through psychedelic treatment, psilocybin treatment in hospital, 2-day treatment. They never drink again.
That's amazing.
So we're seeing new adventures in how the brain works. We're seeing new adventures in TMS, which is the magnetic stimulation programs. So more's coming, and the pharmaceutical industry is driving a lot of that, and that's fortunate for us here and in this country and in other countries. So yes, they're doing more because it's an area of need. It's an area of exploration for the neurosciences. We're learning more than we've ever learned before. Probably in the last 10 years, we've learned more about functionality in the brain than in the preceding 2,000 years, if you will.
Yeah, that's amazing.
They're doing a lot.
So tell me about nView. And then before you do that, you gave me a remarkable statistic last time we talked. And it was, you had said that 80 to 85% of the patients in behavioral health are handled by primary care. And then you followed that up with the statistic that was related to misdiagnosis.
Well, unfortunately, in the primary care space, we've not provided our providers with the tools that let them be very accurate. We've provided tools like CT scans and MRIs and lab tests and all kinds of things to be accurate in the physical health space. But we've really not handed them anything that they can easily do that gets them the correct diagnosis. And often some of the tools that they use actually lead them in a sort of a wrong direction. So making a diagnosis, for example, of bipolar disease, you say, okay, that guy's got bipolar. Well, the question is that bipolar 1 or bipolar 2? Because they're treated differently. But that level of detail and that level of diagnostic accuracy has never been provided well to primary care docs. Primary care docs don't have in the current system time, which is what it takes to understand people sometimes. You don't go to a therapist for a 5-minute appointment. You go to a therapist for a 40-minute appointment. You go to a doctor, and the best you're going to get is 5 to 10 minutes. They're busy. They're trying to treat everything and everybody. So we haven't given them the tools, so they're inaccurate. And that inaccuracy simply compounds the problem often. I get you started on something. Okay, we hope that works. That's the wrong drug. You get worse. Okay, come back. Now I'm down the road. Now I really have to find some help. And unfortunately, in pediatrics, particularly family practice, community health-based systems, there's nothing there to help me make that diagnosis. When I was in practice, if I had time, I could talk to people long enough. And one of my professors used to tell me, if you listen long enough, the patient will tell you the diagnosis. And when I had that time, that was great. But most of the time it didn't. So but I could get a chest x-ray, send them off for a chest x-ray, come back 5 minutes later, I could tell them what's wrong. I can't do that with a behavioral health issue.
Right.
Doesn't happen that way. I've got to spend the time. Somebody's got to spend the time. So giving them tools, sort of in my evolution and in my life of trying to build things, I looked at that and said, that's the problem. I'm not giving you the right tools. I can't expect you to build, a terrific car and give you no wrenches and no car parts.
Right.
You can't. So that's kind of, I think, why we see that. It's not a fault particularly. It's a reality of the world, and we need to address that to help all of us in the primary care space improve on that.
So how do you do that?
Well, I decided that there was a way, and as I looked around it historically, I looked at research, and I thought, well, we've got wonderful things that we do in research. If you do, and particularly if you look at pharma, if you take a pharma study, and how does a pharma study work? Well, they get people and they have inclusion and exclusion criteria. Can you come in or are you out? And those are based on psychiatric diagnoses and a lot of psychotropic drugs. So how do they do that? They don't have 15 psychiatrists interviewing 135 people every day. They have tools. And the greatest of those tools had been built years ago by a guy named David Sheehan, a brilliant psychiatrist at Harvard, was the chairman of the Department of Psychiatry at the Medical School in South Florida. Brilliant guy who built these tools for the pharmaceutical trial world to make these diagnoses and get them right 90% of the time without having to have 5 guys look at a patient, and had all the tracking tools and all the other tools. And then as I looked into other spaces in research, there were guys who had all the tools, guys and gals who had all the tools in OCD, for example, and other anxiety disorders. And they were in all these trials that were going around the world every day. And I said, well, wait a minute, there's nothing over here. So I got with Dr. Sheehan and began to build the concept of I need to take these, and then with Dr. Goodman and Dr. Phillips and a whole bunch of other people that had these tools, let's bring these in, put them on a platform, reshape them, make them a little bit more usable, make them where I can send out a screener that's not just screening to find out if you have what level of depression you have. Send out a screener that helps a primary care doc know what kind of depression do you have. Do you have major depressive disorder? Do you have bipolar disease? Do you have PTSD? Not just you're depressed and good luck.
Right.
So I took those tools and started a company and said, primary focus of this company is going to be to get these. I'll keep using them in research. I'll help my friends in research, and I used the money that we could make on that and started building something that we could hand to doctors, that we could put in there. We could put in their EHRs, or we could put it in a software product, or we could build some apps that would assist them in getting and using the same quality tools that are used by every research project on the planet. Our company now has projects going today on every continent. We probably have 30,000 plus tests around the world. We have it in every language you can imagine. Why not have that here? Why not be able to take that, put a psychiatrist in the pocket of every primary care doc? And so that's what we've been doing. We've been recreating world quality scales into the hands of people who can use them every day.
So if I get this right, I'm getting that initial screener, and then I'm getting a questionnaire of some sorts, and that information goes back to you so that, or as a primary care doc, when that patient comes in the door, and let's say I only have 10 minutes, I'm already armed with the information that's got me to the place where I can say, okay, well, based on your responses, sounds like XYZ, and that I think we have a treatment for that.
Yes, exactly that. I tell docs, look, this is the same flow that you do every day. You listen to people, you get some basic information, you send them for some sort of testing, whether that's a CT scan or blood work or a chest x-ray. This is a chest x-ray for your behavioral health. Now you're armed, doc, when that chest x-ray comes, now you're armed to say you have pneumonia, you have viral pneumonia, you have bacterial pneumonia, you have COPD. I know. I've got my choices of diagnoses, but I've got the right data in my hands. And then secondarily, we're moving into a world where things need to be measured. We need to be able to say the outcome is improving. So we provide follow-on tools so that when doctors comes, let's say I see you and we decide you have depression, and we're going to put you on a medication, and you're going to come back and see me in 4 weeks, and I'm going to look at you and I'm going to say, so how are you doing? And invariably, you're going to tell me, well, I'm better, because everybody wants to please their doctor. But the human animal only really looks back a couple, 3 days. Because if you ask most people what they have for breakfast a week ago, they have no clue. Unless you're like me, it's the same thing every day. But the reality is, in these trackers allow physicians, therapists, and others to see what's going on in between. Is John really getting better? Last week, he was really good. And that week before that, a little sketchy maybe. So now I know how to begin to change my treatment and accelerate the improvement process, if you will.
Does that mean that I'm getting an email like once a week, or
be an email once a week? It could be as simple as what I do with my college students, because college students, one of the things that drives them, particularly freshmen, is loneliness. So I can send out a thing that comes out on one of their smartwatches anytime during the day and say, how lonely are you? And they can hit a button and it says 6. And I can use that 3 or 4 times, and I can start to plot their day. So now my therapist can help them figure out, well, now this is a time of day you usually feel pretty lonely. Let's see what we can do. Can we add an activity? So we can make it as simple as touching your watch. Some of the things we're working on, we can make it as simple as you don't have to touch your watch. Just hold your phone up in front of your face, and it'll tell me your blood pressure. It'll tell me your blood sugar. It'll tell me your heart rate right off the picture on the phone, the selfie on the phone. And there are other tools out there that are beginning to be perfected that we're working with that can actually help people know how they're doing on a particular medication within the first 4 days. Normally we say 4 weeks. So we're getting better at following and tracking and assessing and putting that information back into the patient to say, hey, John, you really are getting better. Because one of the things we know about humans is we want to get better. A lot of times we just don't know, and we don't have the perspective to see how we're doing. But if you can give people the perspective, they like it.
So one of the last questions, then we'll be able to wrap it up. I'm wondering, in a world of value-based care, right? Everybody is looking for outcomes, and you've talked about the data that you gather. Have you been able to yet, I know the company is relatively young, have you been able to yet track, let's say, one system that has implemented your process in all of their primary care sites, and then another health system that seems very similar, but is not using that, and to do any kind of comparative study or ROI? I'm just curious as to what you have.
We're in the process of that now. I started this in late 2016. It took about a year and a half to really get the systems built, and we've done. We have a lot of customers now, and that's exactly what we're starting to do. We're able now to start to look at some of our systems groups that have put our tools into place and say a telehealth program. We can demonstrate increased effectiveness, more rapid diagnoses, shorter times to improvement, as opposed to people who are doing kind of what we used to do, which is you come in, you give me your basic history. I spend 3 visits trying to figure out what's going on with you. And then we see where we go. I don't really know if you're getting better. I give you the medicine. I don't really follow that along closely. You come in, you tell me you're better. I go, yay, I feel good. You feel worse. We know we're improving over that. We're getting good data, and we're talking to people now about how do we crunch some of that data. We're talking to some of the biggest EHR companies on the planet, not just in our country, because we do this not just in the USA. We have clinical folks all over Europe. Australia is a big user of our stuff. Australian folks do a lot of measurement-based care, and they tell us that they give us the data from their before and afters in terms of outcomes. Right now, we're rolling out the entire country of Estonia, for example, every hospital and every doctor.
Wow.
It's not a huge country, but it's a cool little country. But
Still.
the reality is, now everybody's going to have it. They're all going to have access to it. We know we don't have to prove measurement-based care works. We know that. That's been done by lots of people over lots of time. So the outcome of measurement-based care is value-based payment. So we know that the reality for the payers is this system, and they see it, works better than not doing anything. And so we're starting to get that drive from the payers to say, how do we get this out to people? How do we make it better? How do we, the payer, drive this? And in some cases, working with unions who are self-pay, they're starting to see that, and they're starting to do that with some groups now with us that want to use this stuff to help their members. They know it works. They know it drives costs down. We've proven that. So yes, we're doing that, and we're going to keep doing that because that's important. That outcome data is valuable.
Well, ultimately, if I'm a payer, I want to see total cost of care go down, right? I want to look at my my patients that are being treated for behavioral health and, let's say, diabetes, and track that patient over time. Now that we've implemented this program for our primary care docs, to watch total cost of care decline. That would be amazing.
Well, and I think we will see that. I think when you integrate behavioral health, one of the things that we've noticed, particularly when you look at when I used to look at the data sets for my Medicaid program, the number of visits a person makes with a primary care doc before they make the diagnosis of a behavioral health disorder and then after. And it's very dramatic, because the game afoot, when I have a behavioral health disorder and I'm stigmatized and I don't really want to talk, I keep coming to see you until you get it right, until you ask me the right question.
Interesting.
I'll give you the diagnosis. Other pieces of data show us, for example, the mismatch. 50%, almost 50% of people who successfully commit suicide saw their primary care doctor within 30 days.
Wow.
Just in terms of cost to humanity, that's huge.
Right.
Enormous number. And that's not just here. That's not just US data. That's worldwide data. European data, Australian data, other significantly health-driven countries, Canada. We're doing a lot of work with Canadian state-based programs around correct diagnosis, tracking, following, reducing cost, predicting risk. One of our programs is working with finding people in sort of the police officer world and being able to predict when they might be getting into a crisis problem, when that PTSD may be getting too bad, when those underlying disorders that we see in first responders. It's being able to predict that with just some very simple tracking tools into those populations. So there's a lot of good that can come out of what people say is, well, it's pretty simple. We'll just ask them those questions. But the reality is, if you congregate the data right, you get, you get data and then information and then hopefully wisdom. And that's kind of what we're driving. We want to add some wisdom to the program. Right.
Yeah, we would say in my business, data, information, leading to intelligence.
Yeah.
So, Dr. Young, this has been great. I appreciate, the topic is interesting and I don't cover it enough. Like to have more discussions of the importance of behavioral health. I think nView is a fascinating company, and let's keep in touch. I want to see how things progress, and wish you the best.
You too, and come up here and go fly fishing with us up here in God's country sometime.
Oh, Idaho is beautiful. It's been years since I've been there, but it's a beautiful state. Yeah.
Absolutely. Take care, John. Thank you so
much. Take
much.
care. Thank you.
From all of us at Darwin Research Group, thanks for listening. Healthcare Rounds is produced and engineered by me, Kim Ishudo. Theme music by John Marchica. Darwin Research Group provides advanced market intelligence and in-depth customer insights to healthcare executives. Our strategic focus is on healthcare delivery systems and the global shift toward value-based care. Find us at darwinresearch.com. See you next round.